You are listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
How has genetic testing revolutionized the understanding and treatment of hypertrophic cardiomyopathy? In this episode, Dr. Victoria Parikh and genetic counselor Tia Moscarello from the Stanford Center for Inherited Cardiovascular Disease dive into the evolving role of genetics in HCM care. From early detection in families to groundbreaking gene therapies, they share insights on how precision medicine is transforming patient outcomes. Discover how new tools, global collaborations, and advanced research are bringing us closer to personalized treatments and even potential cures. Let's get in the thick of it. Here's Dr. Victoria Parikh and Tia Moscarello.
Thanks for agreeing to be here to talk about genetics in HCM today. I'm Vicki Parikh. I direct the Stanford Center for Inherited Cardiovascular Disease. It's been such a pleasure to be part of the HCM Society. Our center's been around for 15 years, and to watch the amazing science and care and clinical advancements grow for HCM over that time has just been phenomenal. I'm really excited that you're here, Tia, because Tia represents, just I think what is so crucial to caring for families with HCM, which is to help them really understand the way that the disease travels in their family. So Tia, why don't you tell us a little bit about yourself?
Sure. I'm a cardiovascular genetic counselor at the Stanford Center for Inherited Cardiovascular Disease. I work with families with all kinds of inherited heart conditions, including, of course, hypertrophic cardiomyopathy. I don't see patients with any other health conditions. Like cardiology is the thing that I do and my colleagues do. We have a huge center here of 9 genetic counselors, and it's just really our honored to take care of not only the patients in front of us, but their family members, some across state lines. So providing recommendations all across the globe, honestly, and then working in partnership with other expert cardiologists, nurse practitioners, APPs. It's a real honor. So thank you for having us to talk about genetics.
Yeah, thank you. Thank you so much, HCM Society, for hosting us on this super important topic. Our center, as Tia was mentioning, is really founded on the idea that we can identify the root cause of cardiovascular disease, including hypertrophic cardiomyopathy in families, so that we can catch it early before it becomes something that is necessarily life-threatening, or potentially even as we're working on the treatment for this disease to treat it before it becomes symptomatic. And so that, of course, genetics has a huge role in that. I think, Tia, we talk about genetics, and I think that a lot of times we in the cardiology community kind of reduce the idea of genetics to just getting a genetic test, and either it's positive or negative, and then we move on. But genetics is so much more than that for a family. So how do you think about teaching families about what this means for them and for their kids and their siblings?
Yeah, so I will say that genetic testing for HCM has come a long way. We have known about the causes of hypertrophic cardiomyopathy, at least the root causes, a handful of them, for years now. And so genetic testing has been available for 15, 20 years, but there's been a lot of changes in genetics as well. And changes in a good direction, meaning we're able to find the cause for more patients. Now, why is that important? We have been in an era where we didn't really use genetic testing results to a large degree in treating the patient with HCM. It was more used as a tool to triage which family members need to also be aware of this risk for hypertrophic cardiomyopathy and to go get themselves checked out before something happens, before they need to go to the hospital, before they need to, before they have a cardiac arrest. It's still all very important, but we're entering an era where we could actually treat the patient based on their genetic disease, which I think is a really exciting frontier for genetics. And so, Dr. Parikh, I would love to hear a bit what you're excited about for the future of genetic testing maybe even therapeutics in HCM?
Yeah, no, I think that's a great direction to move in because, as we talked about, a cardiologist might say, well, why would I send a genetic test? This patient doesn't have kids, or why would I send a genetic test? It's just going to give me this VUS, right? And what is a
we'll
VUS?
talk about that.
What is it? Yeah, what is a variant of uncertain significance? 50% of the time doesn't tell me anything. What's the point? And so I think you're absolutely right. Not only are we coming to an era where these tests are actionable, which we'll talk about in a second, but also actionable beyond family screening, but also I think we're better at actually understanding which variants cause disease and which don't. And no, we're not perfect, but we continue to improve. So let's talk a little bit about therapy, right? How exciting is it that the first HCM patient received a gene therapy that was precise for their genetic diagnosis this last year, right? I mean, it's really, really exciting. And, gene therapy is something that has come a long way. It started, in I would say the 90s and early 2000s. And of course, the first time that we start any sort of therapy as a society, there are going to be issues and problems with that we learn about. We have come so far in how we deliver that little package of DNA that we can get it precisely to the heart now, right? That we understand how we have to modulate the immune system to protect the patient. And we understand that the packages that we're using to deliver that little piece of DNA, actually may be safer if we use specific types of delivery for these patients. And so, it's not just HCM. Of course, there are other genetic cardiomyopathies that are under study for this type of therapy, but that I think is the holy grail, right? I mean, like we wanted to cure this disease at its root cause, and look what we're able to do now. This is really exciting. This is in trials, especially for patients who aren't helped by the other therapies that were discovered because of our understanding of genetics, right? Like cardiac myosin inhibitors, Cricket, Seidman, Leslie Leinwan, Jim Spudich here at Stanford, coming together with their expertise in human genetics and in biochemistry to say, we think that's what's going on in these patients' heart is not just a tumor. It's not just getting really thick because it's sort of growing out of proportion. It's actually because there's a variant in a gene that's making that muscle work too hard. And when you work muscle too hard, it gets bigger, right? We know what happens when we work out with our arms. The same thing's going on in their hearts. And so then to be able to say, okay, we understand the root cause from a genetics perspective. Let's now take that and extend that to a small molecule that you can take by mouth that's going to tell the heart, you don't have to work that hard. You can slow down. We don't need to, essentially be on steroids here, right? We can actually just do our job normally, and that can help patients feel better. So, genetics as a science has informed our most novel therapies. And we're getting to a point now where diagnosis directly informs the therapeutics that we give with gene therapy. And there's so much more we can say about that. But I want to actually, if it's okay with you, bounce back to that VUS question, right? Because that's sort of the risk benefit of sending the genetic test. What happens in those 50% of cases where I don't have an answer?
Yes. So variants of uncertain significance, big, long phrase. It simply means inconclusive, unclear. We're not entirely sure. And we need to back up a bit to kind of understand why that is. So we all have genes that can cause HCM. The genes aren't the problem. It's the specific DNA difference within that gene, which in medical science we call a variant. Some of us may have become familiar with the word variant because of COVID lately, but we call it a variant. And that is a difference in the way that the DNA is spelled, or the instruction to make the protein or the component of the heart cell. Some people with HCM have a DNA difference that we can find that we know is harmful, that we know would cause the heart to work too hard. When I say we know, that means that there are other people with HCM who have that exact same variant. There are no other or very few people in the general population who don't have HCM with that DNA variant. That we've studied that variant in the lab, in a dish, in mice, and we know that it causes heart problems. That we have computer algorithms that can tell us This is acting very similar to other DNA variants that we know cause disease. So we put all of that information together and can make a conclusion. This DNA difference variant leads to HCM. But we can't always do that. We don't always have, if we find a DNA difference in a patient who has HCM, but that DNA difference has never been seen before in another patient or family with HCM. It's not present in other people who don't have HCM. It's never been studied in the lab. Who are we to say that causes HCM? We simply don't. Who are we to say it doesn't cause HCM? We simply don't know. And so that is that bucket of inconclusive or variant of uncertain significant results. Now, if variants of uncertain significance, I don't want to say freak you out, but if they give you some pause, just know that variants of uncertain significance are very common. We find them in about 30% of our patients who have hypertrophic cardiomyopathy. In the general population, if we look at genes, not just related to HCM, but all genes, I've got VUSs, Dr. Parikh's got VUSs, just in different genes. So, and they're variants of uncertain significance because we just don't know what they do yet. We're hoping that in the future, we will know what they do. And Dr. Parikh and I have some concrete examples in our clinic. Maybe you guys are some of them, where you have had a patient who had an inconclusive DNA variant, and years later, turns out we found 10 other families with the exact same DNA difference. Hey, that's probably the cause of the HCM. So it changes over time with our knowledge, but we treat them. That's important, as if we don't know what they do. We don't test family members for VUSs because we don't know what it means, unless under very certain circumstances, mostly under like an investigational purpose. But normally we don't test family members for VUSs because that family member, if they get a VUS, does that mean they're going to develop HCM? Or does it mean they won't? We don't know. So it's not really useful information. So we keep it in our back pockets and revisit the data behind a variant every time we see that patient in clinic. That's our practice at our center. If you're not seeing a cardiologist every or a specialty center every year or two, check in with them or get updated genetic testing in about 3 to 5 years. Technology changes so quickly, and our understanding of different variants changes quickly as well. So if you have a VUS, you're in good company. You can partner with us to monitor those over time.
Yeah, absolutely. And I think it's such a good point, Tia, that as our knowledge evolves, it might not, people probably don't know all the work that's going into this, right? I mean, You mentioned the fact that these variants are re-reviewed. At our center, we're re-reviewing them. We actually upload that information to a national database that's called ClinVar. And we say, the Stanford Center for Inherited Cardiovascular Disease re-reviewed this variant, and here's what we think is going on, and here's why. And also, there's this huge effort that, Tia is part of the leadership of, and for example, Jody Ingalls is leading the work this year on cardiomyopathies and other causes of sudden cardiac arrest, where experts from around the world come together. It's called ClinGen, and they re-review genes. So if I find a variant or a misspelling in a gene, does that gene have the capacity, if it's broken, to cause disease? And then additionally, individual variants, as Tia is pointing out. So it's not as though we're just collecting all this information and nobody's doing anything with it. There is actually an international effort to be able to understand all of this data. And so that's why, I think, Tia, what you're saying makes so much sense. We have to re-review every few years because knowledge changes. And that's why we're collecting this data, is so that we can help patients understand their genome as our knowledge expands, because their genome doesn't change, right?
Right.
Data that
our knowledge.
Exactly. Our knowledge changes. So we can then bring it back. And so if you're a patient and you've had a genetic test and you have some VUSs, as Tia is saying, if you're not, maybe you've moved, or maybe your cardiologist doesn't have the capacity to sort of help you re-review those variants, there are actually a lot of options that are coming up. You can come to a center of excellence for HCM where you'll have access to a genetic counselor and have access to that sort of re-review every few years. Or, if you don't have the ability to come to a center of excellence, then there are actually genetic counseling companies that will help you to re-review those variants that have come out. So we urge you to take control of your personal data and to say, these are my VUSs. Nobody really knows what they mean right now, but I'm going to carry them with me. And I'm going to come back every few years to my healthcare professionals that I partner with and ask them for help around re-reviewing, because it is hard. It is hard to find a highly trained cardiovascular genetic counselor in the United States if you're not at an HCM center of excellence. So we're here for you. Reach out to us, reach out to other centers of excellence, and we can point you in the right direction there.
Yeah. Yeah. And I think that that's actually a huge part of Dr. Parikh and my role at the center is not only to treat people with HCM, but to better understand their genetic results so that we can treat them and their family better. So it's not just to understand genetics because genetics is cool. It really is going to be useful for our patients and their families. And we've seen that in real time, how family members who didn't know they were at risk for HCM then find out because they have a familial variant, they're at risk, but hey, they don't have HCM right now. Come back and get checked in the future. And that reassurance for them as well as for us, right? Making sure that our patients' family members are okay.
And know that we found this problem and you don't carry this variant.
That's the best part of my job.
Exactly. Go live your life, and we're going to take care of your family. So we did skip over one thing I wanted to ask you about, because I think, there are patients out there who have been diagnosed with HCM because they have a thick heart, but their HCM is not sarcomeric, right? It's not the type of HCM we're talking about where it's hypercontractile and we're overworking that muscle. Genetics can solve that. It can make a diagnosis, like a new diagnosis with a new treatment. Can you talk about how often you help families realize that they have a different type of genetic disease than they thought?
There are several examples of this, actually, and probably the most potent one is transthyretin amyloidosis. This is a condition that typically affects individuals over the age of 50, more typically over the age of 60. And it can look a lot like hypertrophic cardiomyopathy, can look a lot like it, but it's not HCM. It's actually, there are what's called amyloids or proteins that build up in the heart. So instead of the heart working too hard and becoming thick like your bicep when you do too many bicep curls, too many. It's the right amount. It's more becoming it's thick because a protein is actually nestling itself in there and staying there. And this is really important to differentiate between typical HCM and amyloidosis, because amyloidosis, transthyretin amyloidosis specifically, has very specific treatments for it. In the last 6 years, there's been 3 new therapies for transthyretin amyloidosis. And being misdiagnosed as HCM may mean that that person really misses out on life-extending, quality of life-extending therapies. And this, unfortunately, happens more often than we'd like, because these are people who are developing a thick heart in their 60s, and that is not typical of hypertrophic cardiomyopathy. And so their doctors may think you don't have the typical HCM, but really the treatment is so different and life-changing. So genetic testing is important no matter what age you are if you have hypertrophic cardiomyopathy.
Yeah, because on those HCM panels that you order from a company or potentially from your own hospital, they're going to check for amyloid. They're going to check for this transthyretin gene and see if there's a variant there that can cause disease that could explain the thickness in your heart. Because your heart might be thick, but it could be very weak. And it's hard to tell without the genetics, is that because this person, has really, really bad hypertrophic cardiomyopathy that's burned out, as we refer to it? Or is it because they've been collecting this protein in their heart for so long and it's built up and now the heart is failing because of that? And then, of course, the family screening and the type of disease and how rapid onset, et cetera, and the treatments critically, as Tia pointed out, are different. So super important. And that's the best example, I think, is amyloidosis. We have so many treatments coming up for it. We have a great amyloid center here who we partner with Kevin Alexander and Ron Watellas. And, I think that that's crucial to our practice. But then additionally, there are things like lysosomal storage diseases, right? Big, big word for there's a problem with the way that the heart is storing sort of sugars and fats. And the way it's storing them is by sort of keeping them in these little bubbles. And that really causes a congestion in the heart cell and causes the heart cell to get full of those and get thick. And very recently at AHA, the first results from a gene therapy trial for Danon disease, which is a very early and rapidly progressive lysosomal storage disease that can look like HCM, were presented. And they looked very, very reassuring that for the first time, these folks who would have needed a transplant or might have died if they didn't receive treatment in their 20s or 30s actually may now have the opportunity to get a shot, basically an injection that can really change their lives with the appropriate sort of immune therapy. So it's just crazy how much genetics changes the trajectory of these people's lives. And even if there's a VUS, even if it's just a VUS and it's inconclusive, as Tia said, it might change your life later. So there's so many reasons. And just the fact that we have exponentially increased the way that we respond to genetic diagnosis in the clinic with therapies is really critical.
So wonderful. That's so exciting because I wasn't at AHA this year and Danon's a really tough one to watch. So I'm so happy to hear that.
That's a tough one.
That's our future though. Let's get excited. That's the future.
Yeah, exactly. Let's get excited about that. And I mean, there's also the question of, does everybody need gene therapy, right? Is it possible that for folks who have hypertrophic cardiomyopathy with a variant in this gene called myosin binding protein C3, right? That's the one that is in trials for gene therapy. Does everybody with that variant need it? No, we know that carrying that variant is not a 100% chance of getting disease, right? So when we do family screening, we spend a lot of time, and Tia, you'll talk about this, saying, this is not a death sentence by any means. This just means that you have, it looks like maybe between a 15 and 40% chance of developing disease at some point in your life. And it most likely is going to be a disease that you can live a long, happy life with a few, adjustments to your medications. But the reason that we're following you so closely is because there's a not insignificant chance that it will be serious. And so it gives us a lot of breadth of options for folks. And as we learn more and more about the early characteristics that tell us what the trajectory of disease will be, how bad is this patient going to get over, their heart going to get over the next 20 to 30 years, that can help us to inform who needs a gene therapy, who might be okay with a, cardiac myosin inhibitor, or who is, actually going to be just fine. So
just needs monitoring. And I think that's actually worth talking about because some people, the chance that a family member might get disease. So I think that is a big fear for some people about getting genetic testing is like, oh, if I get genetic testing and I find out that I have the HCM and my kids find out that they could get HCM, I don't want to put that on them. I don't want to stress them out or scare them that this is going to happen to them. I hear that. That's a really important feeling and fear. And it's also not entirely true. We know that with hypertrophic cardiomyopathy, the vast majority of the time, if someone inherits a DNA variant that can cause HCM, it's not a guarantee that person will develop HCM. Genes, variants, they pass down from generation to generation. They march through generations, but the expression of HCM doesn't necessarily follow that same pattern. We have lots of families where someone has a DNA variant that causes HCM. They're in their 60s. They don't have a HCM themselves. We also have other families where someone has the DNA variant that causes HCM They don't have any symptoms. They go get checked. Lo and behold, they have HCM, but they're doing fine. They're okay. They go see a cardiologist. They don't need a defibrillator. They're asymptomatic. They're just diagnosed and getting monitored. And so it just because you have a genetic cause of HCM doesn't mean that family members will also develop HCM. And it also doesn't mean that they will have the exact same trajectory as you. They could have a very different symptom burden, very different expression of the disease, all the way to from having as severe symptoms as you to not having any at all. And so to me, it's important that family members know that so that they have the opportunity to take care of their own, healthcare decisions and healthcare choices. It's not 100% at all. Dr. Parikh was saying about 15 to 40%. That's our best estimate. And that's a huge range, but you have to know that every family is slightly different. So in some families, it might be closer to 40%. If you've got a lot of family members who have HCM, okay, you might be closer to 40%. If you're the only one in your family with HCM, might be closer to 15%. We're not entirely sure. Every family is slightly different, even families with the same genetic difference.
And there's some clues that we know, right? I mean, there was some early data from Jody Ingalls and other folks in Sydney showing that, if you are a woman who is diagnosed in her, 60s, and the particular shape of your HCM is what we call a proximal septal thickening. So a really, really sort of discrete, almost like sigmoid shape to the septum, which causes obstruction, right? And has some hyperdynamic function, but itself is not sort of that big, thick sarcomeric HCM, that your likelihood of carrying a known causative variant are lower, and your family history of HCM is lower. And so the idea there is that while we've created these buckets of disease based on what we see on an echocardiogram or see on an MRI, we've defined them sort of by the physiology that we treat, but that doesn't mean it's the same type of genetic disease in the family. And what we're learning now is that diversity really matters. Work from the Sarcomeric Human Cardiomyopathy Registry, which is led by Carolyn Ho at the Brigham, shows that if you have a known genetic variant in one of these 3 genes that are part of that contractile unit, the sarcomere, that your trajectory, your prognosis is different than somebody who doesn't have a known causative variant in one of those genes. And so we are doing as much as we can on the genetic side to subset folks and give them precision therapy, but also precision prognosis based on that genetic diagnosis. And we're also doing work in the lab where we can make every possible genetic variant in a section of a gene and try to sort of proactively figure out how that changes the way that a cell works or changes the way that that gene works, so that by the time we see it in a patient for the first time, we can at least have some idea of whether it affects the function of the cardiovascular system. So a lot coming. And so much that has changed and enabled health for our HCM patients and genetics over the last 10 years. And thank you, Tia, so much for your part in rolling that out. You have been such an amazing leader in this field.
Oh, it's been a ton of fun. Dr. Parikh's leadership as well at the center has been so wonderful. I've worked with you since I was in training. So it's really just been awesome.
And all of your leadership out there, right? Just understanding that this disease has many faces.
Oh, and yeah.
It has more faces than the patients that we're treating, and teaching each patient about their specific disease and listening to them and learning from them. That's what we're all here to do, is to give people a better understanding of what their diagnosis means for them and for their families. And it's only by listening to our patients that we understand that. So thank you all for your work.
Yeah, we treat this disease because of you. Because you have inspired us and are really important to us. And your disease is one that deserves to be conquered.
Yeah, let's conquer it with genetics. All right. Well, thank you so much, Tia. This was a really fun conversation.
Yeah, this was great.
Fun talking to you. And we're going to miss all of you out there. Have a wonderful holiday season and a wonderful 2025.
Talk about your family history at Christmas and the winter holidays. It's a good time to bring it up if you've ever been looking for it.
That was Dr. Victoria Parikh and Tia Moscarello. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.